Hi everyone, welcome to 10-Minute Medicine. Today we're going to be talking about acute kidney injury. My name is Alia Sahni and I'm a foundation year trainee in the West Midlands. So let's start with the stages of an AKI. So there's three different stages and they're based on creatinine level and or urine output. So it's not just both of them together. If someone is reaching the criteria of stage 2 in creatinine level, but stage 1 for urine output, we consider them to be in a stage 2 AKI. So just make sure to consider that when you're looking at results and comparing it to urine output. Moving on to some of the causes of AKI. Now, if someone is calling you to review someone with an AKI or you notice it on the bloods, you want to think about what actually has caused this. Is it pre-renal, is it renal, or is it post-renal? And the main thing, the most common cause of an AKI is dehydration. So you want to make sure you're assessing for dehydration. Hemorrhage, again, you want to make sure they're not losing any blood. And obviously there are some more serious causes of AKI, such as sepsis or heart or liver failure. You always want to also make sure to check the drugs because they can cause a pre-renal AKI, such as diuretics and ACE inhibitors. Then let's look at post-renal, which can be things like a blocked catheter or a renal calculus or a clot or a tumor, on the actual kidney itself causing the AKI. And a blocked catheter specifically is something you can very easily resolve just by flushing the catheter. And now we go to renal causes. So renal causes of AKI sometimes can be a little more difficult to pick up initially, just because they do require a little more testing and things like that. For example, a myeloma screen or with hypercalcemia or hemolytic uremic syndrome, things like glomerulonephritis, you may not be able to pick up just by the bedside, obviously. Things like CKD, again, you'd want to see bloods over time. However, looking at EGFR, you should also be paying attention to that when someone has an acute kidney injury. And just be aware that someone can have an AKI on top of their CKD, and that is a patient who's more difficult to manage. So looking at the investigations, so you want to start with a full set of bloods. So you want to make sure you're doing daily USAMEs because you have to monitor that creatinine. You want to have a look at everything overall and make sure there's nothing else you've missed. So I'd mentioned liver failure, so you're doing LFTs. You want to see CRP, is there any new inflammation? You want to check calcium, like I said before. Hypercalcemia can cause can be a renal cause of AKI. You want to look at magnesium and phosphate more because it's something you just want to be aware of. Clotting as well, you want to keep an eye on just to make sure that it's not deranged. Again, that goes with the liver failure. You want to look at creatinine kinase for the rhabdomyolysis, and you want to do a VBG just to make sure that the lactate is normal, especially since you always want to screen for sepsis. If a patient's creatinine isn't improving, that's when you want to start considering the myeloma screen. And if the patient is actively bleeding or losing blood, you want to do a hemolysis screen. So if they have hematuria, it's very important to do a hemolysis screen. Now look at the ECG as well. Make sure they're not having any other effects of the AKI, such as hyperkalemia, because their kidneys aren't processing potassium appropriately, because that's something that you need to pick up on it immediately and treat immediately because of the serious consequences. You want to make sure to get a urine sample and also do a bladder scan. So this is because obviously a blocked catheter or someone who is anuric can be in an AKI. So you want to make sure there's no urine left in their bladder. You want to also do a dip and a microscopy. Even if the dip is negative, it's always worth sending for microscopy. And if you're concerned or if that AKI, like I said, isn't resolving after a few days, you want to send off a urinary sodium and a protein creatinine ratio. You want to also do a chest x-ray to assess for any pulmonary edema. So that can be a cause of AKI because of fluid. And then you want to do an ultrasound KUB. So that's kidneys, urinary bladder. In some trusts, it's called ultrasound urinary tract. And that's because you want to see any structural abnormalities. So we mentioned the calculus before, but also worth mentioning a Doppler of the vessels because you want to assess for any renal artery stenosis or any clots in the renal artery itself. So make sure when you do the request for an ultrasound KUB, you specifically request for a Doppler. So let's move on to the management. So first things first, you want to treat any complications because those complications can be quite serious. So if they're in hyperkalemia, obviously you want to reverse that based on how high the potassium is. If they're acidotic, you need to reverse that as well. And if they're in pulmonary edema, of course, you want to get rid of that excess fluid. Then you want to assess their fluid balance. If they're hypovolemic, then you need to give them a fluid challenge first, so either 250 to 500 mils, and then you want a background bag of fluid as well. If the patient is in CKD, of course, you need to be extra careful. Again, giving a small 250 bolus won't be a problem, but it's worth flagging up either to your seniors or to the renal team prior to starting a bigger bag of fluids. Now, holding nephrotoxics is very, very important. So you can either check the drug chart or the online drug chart and go through all the medications that could potentially be nephrotoxics. That includes ACE inhibitors, ARBs, metformin, diuretics, and NSAIDs. If you're ever worried or don't know what nephrotoxics are or something, if you're not sure if something's a nephrotoxic, just make sure to speak to the pharmacists on the ward or any of your seniors as well, so your F2s or SHOs. Then again, like I mentioned before, assess and treat any electrolyte abnormalities. So things like the hyperkalemia specifically needs to be treated immediately. Also hypercalcemia needs to be treated immediately because they can have very dangerous side effects. Finally, you want to insert a catheter or assess for catheter blockage. So you want to insert the catheter because if someone's having a worsening AKI, you need to have a very close monitoring on their fluid output. And to do that, you need to insert a catheter. Some patients are very anti-catheter, and so you can also do a convene, which is a version of a catheter that sits on the outside of the penis. For women, of course, we unfortunately can only do the catheter. Assessing for catheter blockage, so you want to either do it yourself or you can ask one of the nurses to flush the catheter just to make sure that there's no clots or debris blocking the inside of it. Then you want to do daily weights and a very strict fluid balance. So you need to assess again, like I was saying, what exactly is going on. And you want hourly fluid balances because you need to make sure we know exactly what's going in and what's coming out. And daily weights is important. So if someone is actively losing weight or gaining weight, it's something that's important to identify. If someone's in pulmonary edema and you're trying to offload that, then you need daily weights as well to make sure that that is actually reducing. And like I said before, you want to make sure you've put out bloods to monitor U's and E's daily because we need to make sure that the AKI is improving and not worsening. So when to refer or ask for senior output. So if the patient is unstable or the AKI is not improving, then you need to make sure to refer them to the renal team. If the patient has jumped from no AKI to like a stage 2 or stage 3 with no obvious cause, so no signs of, they haven't had like CT contrast recently or anything like that, you want to contact the renal team because that shouldn't just happen out of the blue. And they can guide you in terms of certain tests that they'd like you to do. Now, reasons for dialysis, this is something you may have come across before. It's the AEIOU, and it's reasons that people would be hemodialyzed. So that's acidosis, under 7.2 is considered very severe. Electrolyte imbalances, so this is mainly in electrolyte imbalances that are refractory. So if you keep trying to treat a hyperkalemia that's not coming down at all, and it's really not being affected by it, you need to contact the renal team for hemodialysis. Ingestion, so this is any overdoses that people might take, so it's salicylate or ethylene glycol. An overload, so a volume overload would require dialysis to output that fluid, like we were saying before, it can cause an AKI. And finally, uremia. So again, dialysis would be the only way to kind of get all of that uric acid out of the system. All right, everyone, that's everything for now. Make sure if you have any questions to contact us either on the website 10minutemed.com or Facebook or YouTube or Instagram. Thanks for listening.